Awesome. Thanks for joining, everyone. So as you know, this is day 2 of our Sisonke Biotech online conference. Very excited about this. Chris and the team actually are currently at the Deep Learning Indaba in Tunisia, which has been very exciting. And last I spoke to Chris, there's some very good feedback we've been receiving around Sisonke specifically. And we're really excited to see what the next chapter of Sisonke is going to look like going forward, considering all the feedback we're receiving as well. For those of you that are new to Sisonke, essentially, I'll give a brief introduction into it before the speakers go ahead. So how Sisonke Biotech actually started off was pretty much a bunch of us machine learning enthusiasts who had a very keen interest in healthcare. Some of them were actual doctors, decided that we found a very big gap in the African space when it came to reshaping and rethinking the way in which healthcare actually operates within our countries. And what we decided was, with all the knowledge that we have, within the country, from a machine learning perspective, from a technology perspective, we should be doing something about this. And we've seen that healthcare specifically requires some, vested interest to actually get this to ensure that we actually have something tangible coming out, because healthcare is one of the spaces that really needs technology. So essentially what we did was a few of us got together with this interest and with the knowledge in mind, and we decided to start a community which really speaks to the ethos of a free-spirited grassroots community that encourages as many people to join as possible, because we found that there's a huge barrier between technology and healthcare. So part of Sisonke Biotech, what we're trying to ensure is that people can actually start collaborating with each other, irrespective of whether they are technical or whether they are actually in the healthcare space. And we found that there is so much power in actually bringing these two domains together. And if we can actually do it in a safe space where there's an equal understanding around having the ability to communicate effectively, communicate openly, and actually bring about your ideas that we really think we can start working with. And with this ethos in mind, essentially what we've got was some massive interest that we were able to build up. The Sisonke Biotech mailing group is sitting at close to about 100 odd members at the moment, just word of mouth, and just basically showcasing what it is that we actually want to do with this community. And we created a Discord channel where we have a weekly meet where pretty much a bunch of us who are still interested in this space get together, and we speak about anything in the healthcare space, or anything in the tech space. There's been a few projects that have come up as a result of it. One of the most interesting and exciting ones has been the survey paper, as well as the privacy preserving AI for healthcare data sets as well. So those are just a few that I'm mentioning. There's a lot more. And if you'd like to get more detail about this, I will post this core channel, and we'll communicate a lot more of the information going forward. Without further ado, we've got a huge exciting lineup ahead of us. We have some very interesting speakers, and I'm very excited to hear what they have to say for us as well. To start off, we have Darlington Akogo. I'm not going to try and butcher the introduction, Darlington. I'll let you do the introduction yourself. But thank you so much for making the time to speak to us. We're very excited to have you here. Darlington.
Thanks for having me, Chris. So yes, the name is Darlington Akogo. I'm the founder and CEO of minoHealth AI Labs. Let me see if I can get the logo on that. Okay, so yes, that's minoHealth AI Labs. We focus on AI for health, and so I'm going to share my screen now. Okay, so with minoHealth AI Labs, the main objective is to democratize quality healthcare. And so I'll walk through, some of the things that are present in Africa, and then, why we came to that conclusion. So, okay, this is strange. Sorry, let me see. But okay. So yes, there are challenges that exist within health care in Africa. And so looking at this, so if you take, for example, certain conditions like pneumonia, according to World Health Organization, is the single largest infectious cause of death in children worldwide. And then if you take Africa specifically, about 750,000 child deaths are recorded per year when it comes to pneumonia in sub-Saharan Africa, meaning a child dies every 39 seconds of pneumonia. And if you move on to other conditions like tuberculosis, it's also devastating. So in 2016, for example, an estimated 1 million children became ill of TB, and out of that, 250,000 unfortunately died. And then if you come to the popular stubborn one, malaria. So in 2019, we had 229 million cases, and then had over 400,000 deaths. And 2/3 of that were actually children under the age of 5. And, malaria in some sense has become tied to the image of Africa, unfortunately, but it also is the case because basically 94% of all malaria deaths that occurred in the year 2018 actually came from Africa, and that has been consistent. Majority of malaria death is within the continent of Africa. So that is unfortunately why that imagery of malaria, children sick and dying of malaria, is tied to Africa. And more broadly, if you look at something like breast cancer too, we had over 500,000 deaths recorded in 2019. And then if you rate high rates of diseases, if you look at it, part of the reason is the fact that we do not have sufficient number of clinicians. And so if you look at some of the numbers, it starts to paint a picture. If you take Ghana, for example, my country, the patient to doctor ratio is about 1 doctor for every 11,000 patients. And that's not the worst in Africa. The worst in Africa is Malawi. It's 1 doctor for every 60,000 patients. And then if you zoom into, specialized domains like radiology, which is one of our focus, in South Africa, they have 1 radiologist for every 100,000 people. And South Africa is one of the much more developed places within Africa. So if you come to Ghana, we only have 1 radiologist for every 800,000 people. There's less than 40 radiologists in all of Ghana. And if you go somewhere like Liberia, there are only 2 recorded radiologists. And so that is super, super troubling. The fact that we do not have enough clinicians, and also becoming a clinician is not like, becoming a web developer. Becoming a web developer is something that you can take some free courses online, and then so far as you're passionate about it, you can become good enough. So when we, some years ago, were looking at the fact that we don't have sufficient technologists, or we don't have sufficient developers in Africa, we could set up short courses and train people, even for ML, like the way you have the group here and everything. I remember just a few years ago, there were very few people within the space of ML in Africa. And just a short period of time, we've done a lot of training programs across the various groups all across the continent. And now we have, a lot of developers. It's not the case in healthcare. If you're passionate about helping people, it doesn't take a course online to become a radiologist. It doesn't take a course online to become a radiographer, to become a pathologist. It requires you to go to medical school. And this is like 6 years. And then so much have to happen before you are then qualified. So there is some sort of bottleneck, there's some sort of barrier. And even the people that we train, one issue is that once they are trained, they have very little incentive to stay in Africa because those skills are, there's shortage of clinicians globally. And so their skills are also in demand in Europe, in America, in other parts of the world, and they pay much more. So in the medical schools or in the medical field, they also experience a lot of brain drain. So you have a lot of people leaving. So you end up having very, very small people left within African countries to cater for people. The unfortunate thing is that Africa has a lot more of the demand for clinicians, but because we do not have the incentives to maintain them, the places that also have the demand but much less demand and are pulling most of our best. And so we looked at this problem and we asked ourselves, is there something that we could do from a technology point? And so from that, we decided, after looking at different technologies, we did not start with AI, we started with other stuff, but eventually came to realize that the answer could be automating a number of tasks that exist within healthcare so that the very few clinicians that exist will then be empowered to be able to offer larger servicing to patients. So we looked at automating medical diagnosis, prognosis, and forecast. And out of that, we created minoHealth. And so we are a startup with our HQ here in Accra, Ghana, but then we've done a lot of work internationally, have a lot of partnerships, and done a lot of research within that space. So we work on everything from AI for infectious diseases, AI for radiology, AI for biomedical research, and anything in between. So we have a platform where our AI system automatically diagnoses a number of chest conditions, so including pneumonia, hernia, fibrosis, and the list goes on. And so basically this system works by taking as inputs chest x-ray, and then we have a computer vision, or in this case, more specifically, a convolutional neural network that can look at that and then generate outputs that's aligned to the various conditions. So tell you if it's positive or negative, and then its confidence level for that. So yeah, basically this is what the process looks like. And yeah, the potential of this solution is that we can perform diagnosis under 1 minute. In actuality, it's more like just few seconds. It takes 3 seconds or so for the system to analyze one image and then generate a report. And also we can get very good performance out of this, very accurate, and also it's affordable. So the reason why we believe this was a good response to the problem is that with the few clinicians that are available, with a few radiologists that are available, with a tool like this, they wouldn't have to personally go through every patient that comes in and does chest x-ray. And then if you expand that, comes to do mammograms or the other imaging, you can have an AI system that does most of the work. And so the radiologist gets to do the high level stuff and probably only step in when the AI's confidence is low and then they are required. So it's not, at least at this stage, the goal is not to replace radiologists or clinicians, it's to empower them, to allow them to be able to do more. Yeah. So this is interesting. So we've actually been performing clinical trials where we benchmark our AI system against radiologists. And this is data from one of the studies we did in Ghana. So we looked at cardiomegaly and pleural effusion. And then if you look at the performance, you see that the AI model actually outperformed the radiologist by quite a huge gap. So if you look at cardiomegaly, for example, the first radiologist performed 0.77, that's AUC, so area under the curve. So there's an ROC plot that you're seeing here. So first radiologist did 0.77, second one did 0.87, and then the third one did 0.78. Our AI system, we trained 2 separate AI systems, and one did 0.9 and the other one did 0.97. And so that's quite some gap for cardiomegaly. And then also for pleural effusion, you see another set of performance where all radiologists are below 90. The highest here, I think, is 0.86. and the models did 0.91, and then one even did 0.97. So this is based on data from, so the data was Ghanaians, and then the radiologist was also Ghanaians, and then the AI system was also built in Ghana. So we compared the performance, and then we are able to prove with the data that the AI system actually outperformed the radiologist. But again, for communication purposes, the goal is not implying that just because outperform radiologists means that there's no need for radiologists. It just means that when it comes to diagnosing some of these things, the radiologists can make the AI system do most of the work, and then they will focus on much more high-level stuff. So what is the impact we are aiming for? So within the space of AI for health, by developing some of these solutions, we can democratize early disease detection for all. So if you have one radiologist, it's difficult to have that radiologist work within, let's say, multiple countries, attend to different patients. Even with teleradiology, there's a threshold of how much overload you can put on a single clinician. But the thing about having an AI system that becomes a piece of software is that it scales. If 1 million people needed diagnosis all at once at different clinical points and everything, it's possible. The only issue is the scaling from the cloud platform side and then the AWS bills that come with that. But as far as the accessibility, is easy to do that. And so that becomes some of the advantages. Now, if you democratize early disease diagnosis, what it allows for is early intervention. So identifying what is wrong with someone is not the end of the clinical pipeline. Because you identify early enough, you get to respond early enough. And then if you do that, you are able to, achieve higher survival rates and life expectancy. And if you put all of it together, people will then have better quality of life. So if you compare, let's say, the healthcare system in Europe to that of Ghana, one thing that makes Europe really, really good, which is even superior to the US, is that they've made healthcare very affordable and accessible using, the brick and mortar approach, but it still works. And then there's a culture of diagnosis. So, every year you're actually required by most companies to go in for clinical checkup to see what is wrong with you. If they identify anything, they'll be able to respond quickly enough. And ideally, this is what we should have in Africa as well. It's not fair that people in Africa die from conditions that could have been detected early on and treated, but they weren't until the point where it was too late. Meaning that if such a person was born in Italy, for example, they would survive, they would not have died. But because in no action of theirs ended up being born in an African country, they are dying for something that could have easily been identified and treated early on. So we need to do something about it. And I think that gives us the opportunity to use tools like AI and ML, because we cannot do the Europe approach. That's a very expensive approach that we currently, Africa as a continent currently does not have the money for. But then we can use digital tools like this that allow us to scale and then democratize quality healthcare, even without having the necessary infrastructure that will be very expensive. So yeah, that is the benefit of going through this approach. So yes, as part of this, where we have a lot of collaborators from around the world, I will talk about some of the projects that we've been working on. So we work with the United Nations International Telecommunication Union. They are responsible for basically IT technology within the UN. Then you also have the World Health Organization, which I believe everyone here is familiar with. So there's an initiative that is a collaboration between these two agencies. It's called the Focus Group on AI for Health. And so minoHealth AI Labs is a partner on this project. And we actually lead one of the topic groups focused on AI for radiology. So I serve as the chair of that group. And what we do is that we develop global standards and regulations to guide the space of AI for radiology and more broadly AI for health. And there are a number of things that entail that. So there's this whole space of machine learning auditing, which is very important if you are working in healthcare. You know, the old approach of taking some data, creating some model and slapping the two together and then saying my model performed 98% accuracy and publishing a paper, it doesn't cut it in healthcare. If it's only that you want to publish a paper and that's it, that's fine. But if the goal is to have something that will be clinically viable, there's a lot more rigor that needs to go into it. So the space of machine learning auditing, out of this work, we've actually created a platform that automates machine learning auditing. So basically how it works is that this platform will have some hidden data, and then an AI model could then submit its inferences to the platform. Then the platform analyzes it against that hidden data and then generates a report on the basis of the performance of that AI system. So we work with regulators from all over the world as part of this initiative. As a matter of fact, the UK NHS implemented something similar for COVID. So a lot of people were developing AI solutions for COVID. So they came up with this platform that automates this based on some of the discussions that were had within this initiative under the United Nations. This is also another initiative we had with Oxford University. So it was called the Digital Health and AI Global Health Strategy Group. I served as the co-chair of that. So with this initiative is a partnership between University of Oxford, minoHealth AI Labs, and then 13 other institutions from Charité, RKI, even the team that worked on the vaccine from the UK, I believe that's the AstraZeneca. Yes, we worked with them and everything. So we identified some gaps that existed, especially during the period of the pandemic, and then looked at some ways that we can leverage collaborations, work on AI to be able to address them. Yeah, and there's another initiative we have. So there's a partnership between minoHealth AI Labs and Imperial College London. And yeah, so this was funded by UKRI and then NIHR. And this involves using handheld molecular diagnostic devices to be able to rapidly diagnose infectious diseases like malaria. So we use AI within these handheld devices. And this project, I think, yeah, so we actually recently published a paper that looked at broadly digital diagnostics and the potential in Africa as part of this initiative. We have a lot of partners that we collaborated and then work with them on that. During the period of COVID, not that COVID is over though, but the worst of it seems to be behind us. But so during that time, we formed an AI for COVID-19 initiative where minoHealth AI Labs worked with Rand Miller AI Institute, which is our AI training institute. And we did a number of things. So one, we came up with a platform that tracked COVID-19 across Africa. And then we also ran a on that. This was different. Best performing model scored 99.4%. So yeah, basically we were looking at early diagnosis of tuberculosis via chest x-rays. So the task was to be able to classify tuberculosis and then normal x-ray so I was really excited about all the results that for cell biology of infectious pathogens. This institution is part of the World Bank's Africa Center of Excellence. And so together with them, we looked at malaria immunology. We wanted to understand what specific cytokines and antibodies give certain groups of people high immunity towards malaria and other groups low immunity towards malaria. So we collected data from communities that tend to have higher immunity, like there's a town in Ghana called Kintampo. They tend to have higher immunities. So we collected data from them, bio data, and then Accra, people tend to have lower immunity. So, we collected data from them as well. Then we use machine learning to be able to see what in all this, because we collected a lot of variables, which key variables did a good job of separating these two groups, and we're able to identify some key ones. So this has a potential of helping when it comes to immunotherapy or even in the fight against malaria. This has identifying those key biovariables to be able to allow us to better fight malaria. So yeah, we've had the honor of being featured on a number of platforms, collaborating with a number of including African institutes. So hello.
Yeah, we can hear you.
I think you broke up, Darlington, just at the end when you're asking if you had any questions. But I have some questions on my side. I was just curious what the size of the data set for your AI radiologist or AI radiology system was, and if it was something that you funded yourself or open data. So when we talked about the ROC curves for your system versus the clinicians.
Sorry. Yeah, I was actually saying that I saw some questions in the chat. So I believe that was your question. So
yes.
You mean for specifically the test, right? Not the training of the model. So for
yes.
the test, the one where we actually benchmark or compared the AI system with the radiologist, we looked at 100 samples, but then out of that, we did another test, which was just the AI system. And for that one, we used about, I believe about 500 images or 500 samples. But yeah, because, the radiologists would definitely not be able to make the time to do all 500, we reduced it to 100 and then benchmark them. So yeah, use 100 samples.
Okay, I just have a follow-up question on this. I'm just curious if we're able to label X-ray images faster without a clinician. Does that mean that more people get an X-ray image, which means we can diagnose more things faster? I mean, is there also a bottleneck on the hardware side? So is there still a cost bottleneck for getting the X-ray images to start with?
If I understand your question, is it about you asking about the imaging or the analysis from a radiologist?
About the imaging. Yeah, so to improve the
also, I
quality
just
of care.
realized that the other
Yeah, sorry, I think we have a delay, but
sorry,
I'll let you
repeat that
speak.
again.
I think we've got a delay on the line, but my question was just if you can image more people, does that, sorry, without imaging more people, does that improve the quality of care, even if you're able to label these X-rays more cheaply?
If you could image people, so you mean with the actual, let's say, X-ray machine itself, right?
Yes, exactly. I'm just saying with your solution, you're able to label the X-rays without a clinician always, but is there not still a bottleneck of getting more people imaged to start with?
Yeah, is there not still a bottleneck of? Sorry, kindly give me a few seconds.
You've raised an interesting point though, Oliver, because so I'm not in the clinical space, but I've seen that sort of bottleneck happening in the NLP space. For example, when you're trying to label document data, the AI system tends to work a lot faster than your actual people that's sitting on the other end consuming this information as well. And sometimes we just end up producing way more information than people can actually keep up with. So that is something I've seen, at least in document labeling specifically. So,
Okay.
yeah.
Yeah,
Yes.
I'm just curious. There's no right answer. Yeah.
Yeah, I don't know if I understand your question correctly. You're asking if there's a bottleneck with the speed of the image in itself, right? Beyond looking at labeling the images, right?
Yes. Well, taking an image is still going to money. So without investment on imaging to start with, will we fall behind even if we can assess these images quicker?
So what I would say about that is, sorry, I'm hearing that we have some emergency in the hospital. Is it really an emergency?
The real world of the doctor's life. I think this has been very interesting. Just for everyone on the line, what are your thoughts so far after hearing about this?
Yeah, sorry about that. So this is well, I guess this is very much connected to what we are discussing. So we are working on a project where we are looking at automating the detection or diagnosis of malaria from microscopy or microscopic images, which I didn't even mention about. But so we have a team that is working in one of the hospitals, and something came up, and I would have to address it at some point. But yeah, to answer the quality way, if so, there's a lot of international development agencies that are operating within healthcare in Africa. It's easier for entities outside of Africa or even within Africa to donate what's the name, imaging devices than it is for them to send a radiologist. So yes, the hardware is an issue, but it's actually not as much of an issue as the clinicians themselves, the radiologists themselves. So you would actually go to facilities that do have the imaging devices, but they only have 1 or 2 radiologists, and this facility sees like 100, 200 people coming in per day because it's a regional facility, but there are not that many clinicians. So there is a hardware problem, but it's not as urgent or severe as, you know, being able to analyze the results. And to use the devices, usually will work with radiographers. So the ratio of, you know, patient to radiographers is actually better than the ratio of patient to radiologists. So there is that. But even for us, I mean, we've had long discussions about the hardware components, and we have some plans along those lines. I think in the long term, we need to be able to build much lower. So it's not about just the availability of the device, the pricing of the devices. They are very expensive. These imaging devices can cost anything from around, let's say, 100,000, some tens of thousands of dollars to hundreds and thousands of dollars. They can get really expensive very quickly. So we looked at, you know, are there other techniques that we use to image certain diseases that will be cheaper. And so like there's a lot of problem, and then you rank them and start with which is the worst. And we believe that being able to analyze the images, the shortage of radiologists is a much bigger problem than the availability of the devices themselves and how quickly you can image people.
Yeah, that's really interesting.
Still getting imaged, but no one is available to be able to rapidly look at those and tell them how they are doing. And the pricing is also expensive because of the radiologist component and then the availability. You can wait like a day before they get the result back. So that's a much more urgent problem than the availability and the speed of imaging. Does that answer your question?
Definitely, yeah, that's very comprehensive. I think it brings another point to it. I think if you would be able to, that you're able to image more people as well with this technology, rather than just process the images faster, that would be really interesting. But yeah, it's clear you're thinking about how you get more hardware and more images of people.
Yeah. I think there were other questions you asked. Was this something you funded or open data? So we had partnership with hospitals, and this was more of, so the goal of this is to test our
Darlington, we're
technology that is part of our plan, our self-fund. Hello?
Sorry, we're struggling to hear you. Maybe just stop sharing your screen. I think there might be a bandwidth issue on your end.
Oh, okay.
Maybe it'll be better. Okay, let's
can you hear me
again.
now? Is it any better?
Yes, that's perfect.
Okay. So yeah, I was saying that, let me look at the chat again. So I was responding to the question about, whether this was funded. So yes, this is a research that we're doing. So basically we're testing our proprietary AI system. And so we internally funded this whole stuff, leverage our partnerships with hospitals to be able to do this. And so the data is not open, but we have other projects where the data is actually open, like the microscopy research I'm talking about is funded by Lacuna Fund. And we are doing it both in Ghana and Uganda. At the end, the data will be made public. So we usually mix the two depending on what we are doing. There are certain things that the data is kept private, and there are certain things that we make the data public.
Fantastic.
Okay.
Yeah.
Any other question? Let me see. Also, okay. Is there any other question?
Yeah, so I had one question. I mean, we all know the healthcare state in Africa is not the best, and a lot of the time there are technical challenges that you will encounter when trying to implement a solution like that. What are some of the challenges you've experienced while implementing minoHealth so far?
Yeah, there's been a lot. So, well, I can say literally what was brought to me now is one of the challenges. So when you're working with, in healthcare, the places that need a lot of assistance tends to be the public health facilities, but they also have a lot of bureaucracy. That might vary from country to country, but the public health facilities that we have encountered, the larger they are, the more bureaucratic they are. So certain things take forever, take 1 million approvals, and sometimes that gets in the way. And we work on regulations and ethics, so I appreciate them a lot. But I think sometimes people create unnecessary, over bloated, pipelines around ethics that is no longer really about ethics and ensuring good health. It's just unnecessary processes that exist that frustrates innovation. So those are some of the things that we also encounter. And even though we are building some of these solutions to address infrastructural gaps, certain infrastructural gaps even impede the ability to do some of these things. So the data that I mentioned that we collected about, 500, I think in total we collected about 1,000 samples and then selected the ones that match the conditions we're doing at the time. To get that data, we went through a number of hospitals and realized that some of them did not even have that kind of data. Not because they were not imaging that number of patients and everything, they were. We've gone to one of the largest facilities in Ghana. They image a lot of patients, but they don't keep record, they don't keep digital copies of it anymore. And this gets worse when you move away from X-ray and you go to some things like CT scans and even other imaging modalities where one file can be, let's say, 200 megabytes or much larger, sometimes even 1 gig. So it becomes difficult for them to store that data. And so when you go in there that we need this data to test this solution and do this, there's no data available. They don't keep it. Some don't even have digital copies of it. Even the hard copy, because they are running a referral model, they just give it back to the patient to take to whichever hospital they came from. So there are still all these challenges that exist, but it's not. It doesn't make it impossible to do certain things. You just have to, persevere. So you run into all types of issues and you have to rapidly come up with solutions to address them. It's a tough space.
No, I completely understand. And I think it's the only way to do it. So thank you for keeping on trying. I know it can be very frustrating. I just have one more question on my side. With regards to adoption, how well are the clinicians taking it around? I mean, because essentially, it may seem to them that you're kind of taking over their jobs, right? So how have you been going around in terms of managing that specifically? And yeah, I think just it'll be helpful for all of us to understand that, because I've encountered that several times as well.
Yeah, so I would say, if you notice during the presentation, I repeatedly was saying that this is not meant to replace clinicians and mention that for communication purposes. So that's a lesson we had to learn very early on. When people in AI there's a lot of hubris. Let me be honest. There's a lot of hubris when you come from the world of AI and you believe that you have the power to, automate and take away everyone's job. And so people in healthcare, you might go around saying, oh, we are building this. And I remember very early on when Jeffrey Hinton and the rest would say, oh, in like 5 years, there'll be no medical doctor or radiologist anymore. All radiologists will lose their job. Those comments, if you make comments like that and you go to hospital, they are definitely not going to work with you. They would avoid you and they will even hospital administrators wanted to work with you, they would collect the data, testing the models, we even benchmark them, all because of how we communicate. So we tell them that this is meant to make their work easier by allowing them to be able to attend to more and more patients. And so they don't have to spend their time doing some, unnecessary, or let's say some low-level tasks, and AI system can deal with that, or just reduce the volume of workload. So if you're coming from that angle, it's something that they face, they're overwhelmed. So if you tell them that I'm providing this solution that you can use to reduce your workload, then they'll appreciate it. But if you walk to them and you're like, oh, I'm building something that will take away your job because, I think me just working over like a couple of months, I can do something that took you 20 years of experience to gain, that kind of hubris definitely will not allow them to work with you. So communication, that's the key.
Agreed. And I think it's always important to position yourself with the right intentions as well to prevent that. So I love that approach. I keep thinking of new questions to ask you. So I've got one more question to ask you. with regards to the data that you are collecting at the moment, are you using it to retrain your models going forward as well?
Yes. So that's a good thing about AI, which is that with the more data you get, you can always improve the system. So even if you look at the ROC curve, for example, we had 2 models in there. And so every time we are always looking at new data, improving models. And sometimes apart from improving models, we're also looking at a different set of data for different problem, and therefore even building new data pipeline. When we started, the first one took so long just getting the data to training a model to then testing that model and everything. But we want to over time keep improving that. Currently we've improved it, but there's so much work we still need to do to improve that pipeline so that in a very quick process, we go from collecting that data and then testing them, like building models, testing them, and then also the regulatory aspect too as well. So that's another component that we've currently started looking at. So all of this falls under the software as a medical device component. There are some things that you need to follow, compliances, regulatory approvals, and all of that. So I believe as we go on, we should get to a point where if we take some new condition and say, hey, this is a major problem in Africa, we want to have a solution for it, it should just take us a very short period to go from collecting data and then ending up with a solution that clinicians can then use. Yeah.
I'll probably reach out to you a bit later, Darlington, because I've got a lot more questions, specifically around the privacy of the data set itself. I can imagine it's something you're probably super passionate about as well. But thank you so much. I'm just want to ask the rest of the audience, are there any other questions that you guys have for Darlington? Feel free to unmute yourself and ask the question if you'd like to. Okay. Doesn't look like there's any other questions. Thank you so much for your time again. I definitely learned a lot, and this time I'll be reaching out to you soon as well. Thank you so much, Darlington.
Thank you. Have a awesome
Thank you. All right. So our next speakers is actually a deep change